everyone. Good evening. A very warm welcome to you from the Australian National University here in Canberra. I hope you and your loved ones are keeping safe and healthy. My name is Dipti Talaulikar. I'm a hematologist and the program lead for the Global Peer Support Program at ANU. Joining me today are Devashi, a medical student who is volunteering with the program, and Dr. Pinky Dharmashaktu. We are delighted to have with us our speaker for today, Dr. Nick Coatsworth. Nick is one of Australia's key medical leaders and has held a national role in the Australian response to COVID-19 as the former Deputy Chief Medical Officer. Closer to home, he is the Executive Director of the Medical Services at the Canberra Hospital, and he has a very long and illustrious career which spans a number of domains. And I don't know how he finds the time, but he's currently also doing a part-time PhD at the Australian National University. Now, before we start, I would like to acknowledge the Ganawal and the Gambri people who are the traditional owners of the land from where we are broadcasting to you. And I pay my respects to the elders past and present. So without further ado, I will hand over to Nick now.
Well, thank you very much, Dipti. And I just wanted to say thank you for the invitation and just echoes Dipti's sentiments that I hope everybody online and their family is keeping as safe and well as possible. And I acknowledge that the experience of COVID-19 around the world has been vastly different depending on which country you come from and the challenges, particularly in India, in battling this pandemic. What I wanted to do today was perhaps share some of our own experience in the intensive care setting, and in particular share with you a novel platform that we developed quite early on in the pandemic, which enabled us to get a sort of cross-national view of intensive care, bed supply and surge capacity. Now, that may initially appear to be a relatively straightforward thing to do in a country like Australia. The issue is, though, and some of you may be familiar with this, is that Australia is a federation composed up of 8 jurisdictions. And one of the challenging aspects of that is that each jurisdiction has its own government. We have a 3-layer government system of government, and for that reason, each government and each jurisdiction has its responsibility for their health and hospital system, but more importantly, even has the responsibility for public health. So in order to get a national picture, it requires usually a lot of agreement between the different layers of government and the data to be sent, usually through the Commonwealth, which is the federal government, of course. The data gets sent to the Commonwealth and then distributed back at aggregate level. What we needed to do, though, was have a much more real-time impression of exactly what was going on in intensive care. And we know that one of the battles with COVID-19 is that the intensive care system gets overwhelmed very quickly. So what did we do? This was very much a collaboration between the federal government, of which I was the major interlocutor for this one as the Deputy Chief Medical Officer. I'm an infectious diseases physician, but have had some experience in humanitarian and disaster medicine and with our federal disaster response structures. Also, the Australia-New Zealand Intensive Care Society, which were the main drivers for this, and one of our jurisdictional partners, Ambulance Victoria. Now, Victoria being our second most populous state, and the ambulance department down there had a couple of key intensivists that drove this. The first thing that we did was get a snapshot of exactly what the surge capacity was. And you can see on that slide there, the Medical Journal of Australia published this. And that really formed the basis of this database. And the reason that study was so effective was because it reached out and got data from about 85 to 90% of intensive care units around the country. We have a dual system in Australia, a public-private system. And so a dual system in Australia and we captured data from both the public and the private intensive care units, which was really important to get a whole of nation impression of what our capacity might be. There are at any one time about 2,500 ventilated beds within the public system, and we realised that we could probably surge that to about 100%. So we could get up to 5,000. And so we made our decision making around ventilators and so on and so forth on that sort of premise and how many ventilated beds we could actually support. The idea of this CRIS system, the Critical Health Resource Information System, was actually that the intensive care unit directors and their senior nurses would input the data every single day as to how many COVID-19 patients they had, how many ventilators they had available, how many people were on dialysis. And in that sense, we could get this sort of ground up, or I should say grassroots data capture nationally, which meant that all the usual data filtering that went from hospital to health district to state government to federal government, all those layers were removed. And now we actually have a national real-time impression of our COVID-19 intensive care burden. Just moving on to the next slide, this is the data that we were able to capture from the CRIS system. And I focus here on what we termed the Victorian second wave, which really occurred around here in September of 2020. So as you can see in the top graph, the black line here, if my cursor's, you'll see in the top graph, the black line represents the number of patients with COVID-19, and the more pale blue was the number of suspected or the total number of suspected cases. So just running through that again, the black area is the COVID patient numbers in ICU each day. The light blue is probable COVID. Now, if you go down to the graph below, the scale on the left actually moves to the hundreds rather than the tens. And you can see the relative number of other patients, surgical and emergency, surgical and medical patients in relation to COVID-19. So you can see that the burden of COVID-19 as a relative proportion of patients in intensive care in the Australian context on a daily basis was really quite well managed. We didn't have a big burden of COVID-19, and overall the system was not overwhelmed. In fact, in our context, the demand was very, very localised. So you had some intensive care units, particularly in northwest Melbourne, our second most populous city. They had significant numbers of COVID-19, and they were under stress in a similar sort of way that we've seen to other intensive care units around Australia. So if we move on to the next slide, you can actually see a little bit of detail about the sort of information we captured. Now, we were able to see in real time on a per hospital basis. If you look on the left, even though that's a little difficult to see the individual names of the hospitals, but each of those was an individual intensive care unit. And it showed us the total number of beds that were available, the total number of beds that were occupied, the total number of beds that were occupied by COVID-19 patients, the total number of staff that were sick or isolating because of COVID-19. Generally speaking, it was isolating rather than unwell because of COVID-19. It also gave an impression, if you look at the right-hand side of that slide, which is the summary page for COVID-19 Victoria, you can see the total number of cases at that snapshot, which was the 20th of July of 2020. There were 47 patients in intensive care units in Victoria, and 26 were on ventilators. And you can see then a resource snapshot of available versus ventilators that were actually in use, how many patients were on non-invasive ventilation, and how many patients were on extracorporeal membrane oxygenation. The rationale for this national picture was that we had anticipated the sort of wave that had affected India, the UK, the US, and that we would run out of ventilators. And so the desire to create this system whereby we could actually load share across the entire nation was summed up by that statement that you can see there. Why would you let a patient die in Western Australia if you could see a spare ventilator across the country in Sydney? And so there was actually a plan that we assisted with creating at federal level that underpinned this national database that would allow ventilators and dialysis machines and other resources to actually be transported across the country to where they were most needed. So if we go on to the next slide, we have a look at the burden that was created in the hospitals in the Melbourne area. So this is a sort of a snapshot of our second major city, Melbourne, and you can see that there were a series of sort of hotspot areas, quite geographically localised, in fact, in the city, and often within our lower socioeconomic communities, often first and second generation Australian migrant communities from overseas. And the reason for that is this is going on in our largest city, Sydney, at the moment. The reason for that largely because our first and second generation migrant Australians formed the engine room of our cities, working in essential industries such as aged care and home care, such as food distribution centres, you name it, these Australians are keeping the country running. And so it's very difficult if you move into a situation of movement restrictions. Movement restrictions work quite well to stop COVID in people like myself who have stable, well-paid full-time jobs, but they work less well in amongst communities where it is economically impractical not to go to work, or indeed them not going to work might cause significant disruption to essential services. And as an interesting point that you may not be aware of, there were significant concerns about food distribution across the whole of the eastern seaboard of Australia during the Victorian second wave, and that's not something that's commonly known. So moving on to the next slide to see how Chris helped us with this. You see the yellow dots there are the metropolitan hospitals, and we've got 7 of them there that really represent the metropolitan intensive care units within Melbourne. And then you can see that the CRIS database actually enabled us to generate what we called an activity index. And the activity index used the data points that I mentioned before. How many COVID patients were actually in the ICU at the time? How many patients in total were in the ICU? How many staff were off sick? How many dialysis machines were being used? How many ventilated patients were there? And there were a few other metrics, but comparatively small data set that was easily available and reportable from each ICU. And what that did was create this sort of activity index that one of the key authors on this paper and one of my key collaborators, David Pilcher, came up with his team. And that activity index was used as a predictor for when these hospitals would need to transfer patients out. And I guess the main point of this slide was to demonstrate that the activity in intensive care units was not uniform across the Victorian second wave. So as you can see, we have Hospital B here, which may well have been Royal Melbourne, I'm not entirely sure. But at various time points, Hospital B, Hospital A and Hospital D had the most activity, Hospital C had a modest activity, and Hospitals E, F and G had very modest activity indeed. And what that meant was that rather than allowing a single intensive care unit to be overwhelmed, there was load sharing going on where patients were actually transferred from the busy intensive care units to the less busy intensive care units. We know, of course, and many people on the line will have far more experience in this than me, but that the risk to staff of nosocomially acquired COVID-19 infection goes up dramatically when your activity increases and when your system is overwhelmed. So there was a deep desire to avoid that, and I guess, even with a modest number of patients, we were observing some hospitals reaching relatively high activity indices and demand. Although, in fairness, it's true that because of our low COVID-19 community transmission, they were not really close to being overwhelmed. And if we can actually see some of these time points coming up on the slide now of where the activity index sort of exceeded the what we would define as high activity, and that they cluster in different positions, and that load sharing was certainly a potential option. And those dots actually represent when the patients were transferred from intensive care units, from one intensive care unit to another. One of the things, for those that are interested in disaster medicine and sort of the systems behind it, this system allowed the sort of immediate visibility for the coordinating ICU clinician group and Ambulance Victoria. One of the things that we've really benefited from, I think, here in Australia, and I think we're demonstrating it now with this interconnected discussion that we're having across nations, really, is that the value of medical networks is really important. So the network that we already had with the Australian New Zealand Intensive Care Society allowed research to take place, this database to come into existence, and then at a local level in the city of Melbourne, the intensive care specialists were meeting on a daily basis and working out not only how best to treat these patients, because keeping in mind this was 2020 and our knowledge of intensive care management of COVID-19 pneumonitis was in its relative infancy, but also how to distribute the patients to the place where they could get the best care. Moreover, you could do what we call ambulance diversion. So non-COVID-19 critical patients could be sent to ICUs that were had more capacity. So that was certainly a positive outcome of the CRIS system, and the CRIS system's continuing today. Our preference was to transfer intubated patients rather than non-intubated patients because of the very real and we know very quick deterioration that COVID-19 pneumonitis can cause. The other thing to keep in mind about this load sharing system is that a lot of the ICUs, remember that study I showed you at the start suggesting that we could surge to 5,000 beds. That was fine in terms of, yes, we had the beds, yes, we had the ventilators, but many ICUs ended up finding that they couldn't actually open any other beds because they simply didn't have the staff. The reason we didn't have the staff was not because the staff was sick, but because the public health teams were putting them into quarantine and isolation in order to stop the spread within the hospital. So that was our particular capacity constraint. Obviously, in other places around the world, it was genuinely because the staff themselves were sick with COVID-19. So I'm just coming to the end of the discussion. I was hoping for perhaps some questions. Please feel free to put some on the Q&A. What I might close with is the situation now. So here I've got my mobile phone, and I can tell you, obviously I can't show this because it's an internal government platform, but I can tell you how many people there are in intensive care. Now, most of our people in intensive care at the moment around the country are in New South Wales, where we're having an outbreak of the Delta strain. And we have 58 confirmed COVID patients in intensive care nationally and 24 ventilated patients. Now, obviously, that is a drop in the ocean compared to what other nations around the world have experienced, but it is very useful to have that as a decision maker really on a mobile device, and we can go to any hospital now in the country and actually look at what their COVID-19 status is. So that's the CRIS system in a nutshell. It's something that's probably quite particular to Australia, and I thought that it was worthwhile sharing. I'll stop my screen sharing, and I'll open up to any questions. So we've got one question here. I might read them out. I'm sure you can see them on the Q&A. But what parameters and in what order should the local government look at when deciding which locations to start building additional facilities to prepare for the surge in ICU admissions? Is population density the primary factor, or what should we be looking at, or should we be looking at other factors? I think that's an excellent question. I would answer it in terms of our own experience, which would be have to be modified slightly to one's own context. But in terms of where our metropolitan health services are, it's probably population density, because we put our major teaching hospitals, so they're not often equidistant, but more or less a local health service in Australia in a major city covers approximately the same number of people. Then if you're going to use a load sharing model, you probably don't want to transfer people too far. So that's an answer from the Australian perspective. I suppose we've been advantaged in the fact that we haven't faced that situation where we've had to actually build things. We've got another question here. While it would have been relatively easier to plan for the movement of physical resources, how did you go about sharing skills? How could we learn from the experience of intensivists in India to prepare for the onslaught of the Delta variant? Well, Devashi, did you want to? I'm not sure if I can answer that. I would imagine that the experience of intensivists in India would be very, very useful. I think one thing that I can say is that we trained about 20,000 of our registered nurses who were not intensive care nurses to increase their competency through an online training program in anticipation of the need for human resources. We would move human resources around the country probably within our state borders to start with, but within cross state borders would be a difficult thing for us. I'll move on to the next question. Is a system like CRIS transferable to other countries like India, Indonesia, facing a more severe COVID crisis? Yes, it absolutely is. It's a very, very simple web-based system. And actually, the data custodians are the Commonwealth government, and there would be no problem in actually, asking to replicate it. I think that would be a very interesting thing to do. It's very easy. So when we talk about challenges in implementing the system, it's really about the challenge that we had was about buy-in from the local hospitals themselves. So we had to, and obviously this is an order of magnitude greater problem in India, but we would have to actually call the directors of the intensive care units and ask them in the first instance, in the first couple of weeks, to input their data. So it was very patchy for the first 6 weeks, but we literally had a project team calling individual hospitals, reminding them to input data until they actually had a sort of consistent approach to it. There's another great question here. What would you do differently if we had to do this again? Look, I've got to be honest, this was one of the quickest, cheapest and easiest to implement projects that I've ever been part of. I think that the only issue in some of our jurisdictions, some of our states, was that the doctors at the ICU wanted to be part of it, but their sort of political masters were less happy in sharing the data. Now, that's not a issue peculiar to Australia, which is, it can happen in any country with multiple layers of government. So it's not, the clinical buy-in is the most important. So the networks that you can leverage through your own intensive care societies is the most important. But don't forget that you do actually work for generally speaking, within government system, and you might have to answer for your use of data. I will comment on the private system though, because as I said, we have a dual system, and that is obviously relevant in India. So we got the major private providers and talked to their senior medical directors and got their buy-in as well. So there was some concern that the privates wouldn't actually input the data because they're not used to sharing data nationally, but we were able to do that as well. Question here regarding paediatric ICU interventions. Yes, there was definitely, in actual fact, most of the paediatric intensive care is delivered through specialist children's hospitals. So they had their own lines. But for those hospitals that do have an adults and a peds ICU, that is the minority. They were able to input things separately, so we got an idea of the children as well. Rajiv's asked us, when ICUs were overloaded, did we use a triage criteria for allocation of limited resources? I share the experiences? Rajiv, this is where it gets very, very different. And I suppose we, from an Australian context, feel deeply for colleagues who have had to experience the need to triage resources. I've had to do it myself when I've worked overseas in other nations, but fortunately in Australia, we haven't been in a situation where we've had that. And to be honest, we have to acknowledge that the major contributor there is the fact that we're an island, and we're able to close our international borders and control the entry of COVID-19 very, very carefully. That's how we, there were other factors to do with our policies and a more modest population, but we never really got overwhelmed. I like this one. The federal setup is a pain in India, as I'm sure it is in Australia. Thoughts on how we could get the states working together better during these times of real need. So I might share with you an interesting issue in Australia at the moment, which is that we are challenged to get our population vaccinated quickly because it is difficult to see the need to get vaccinated and take action on an individual level when we don't have as much COVID-19. Interestingly, there's been some discussions in Australia recently of cross-border transfer of vaccines to the places where they're most needed in Australia at the moment. And that's been a very difficult thing politically to get agreement on. So I think that the only way to do it is from the bedside as a clinician, and that is that our clinical leaders need to speak up and what we would term give frank and fearless advice to our political leaders. The CRIS system is a good example of succeeding with that, where you can convince the political leaders of a need and you can get buy-in. But I think if you expect them to work it out on their own, then they sometimes come to a different conclusion than us clinicians. Now, we've had a question, where can we get more details of the digital dashboard we mentioned, which might enable collaboration across the country? Well, generally the request would need to, because it's a federal government thing in Australia, any request on how to do it would have to come through the Federal Department of Health and the Federal Department of Foreign Affairs and Trade. But in terms of the construct and how it's done, if we can get an email through the international email address at ANU, then I can certainly provide details of the back end, which is technologically, which is very, 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 very simple. Now, is there any monitoring done for mental health facilities when a surge occurs? What a wonderful topical question. And no, there isn't, which I think is probably something that we can all take away from this, that we, in COVID, we have very much focused on the critically ill from COVID, and perhaps not set up the same sort of monitoring systems for other aspects of our healthcare system. So I think that's a wonderful point, but not one that I can give a satisfactory answer to. What advice can I give India as it prepares for a potential third wave? I feel uniquely incapable of giving any advice. and sort of see the situation in India with a high degree of humility. It's, in many ways, it's beyond comprehension compared to what we've seen here. I think from this talk, I would take away that the capacity for inter-hospital cooperation is critical, and you will have a sort of force multiplier effect by working together. Now, my experience of the Indian system is very, very limited. Maybe reflect on the US system, where the individual hospitals are very much run, as many of you will be aware, by individual providers. And whilst I'm not sure what's happened with COVID-19, certainly when you looked at disasters like Hurricane Katrina, there was very little cross hospital cooperation. So don't try and tackle this on your own as an institution, would probably be the best advice that I could give from this talk. What is Australia doing to use its expertise to help other countries? Well, there is a $500 million, in fact, it might be $750 million aid program, which is mainly focused on our immediate region. So we're talking about the Papua New Guinea Pacific nations and ensuring that they have their vaccination programs are supported technically and also with supply. There's obviously the work that's being done with, the research that we do into COVID-19 through our intensive care society is partnering with nations across the world. So we've contributed to a number of large ICU data sets that have helped, I guess, refine the treatment. One of the things that you may wish to have a look at, which is freely available, is the National COVID Evidence Task Force webpage. I'll just mention that again, the National COVID Evidence Task Force. And that was a federally funded initiative through the universities in Melbourne, Monash University, I think. And that the Evidence Task Force provides a living guideline. So it's, when I say living guideline, I literally mean that they've got researchers looking at the literature on a daily basis to see whether there's anything new that needs to be placed in the guideline. And that has a whole range of information on different treatments for COVID-19, different treatment strategies, infection prevention and control, all updated with the latest international evidence. So I think that would be, as at a clinician level, that would be one of the most important contributions that we've made to the sort of international body of literature. I know every nation's got its own guidelines, but I'm not entirely sure that anyone's actually got a living guideline. And thank you for all these questions. It's wonderful that they continue to come through. Most of the current ICU admissions in India are mostly non-vaccinated. In Australia, mostly non-vaccinated. Well, I can tell you entirely. The only person who is in ICU at the moment who had a vaccination had a single dose of Covishield, which is the AstraZeneca vaccine, but the remaining people are all unvaccinated. What difficulties or hurdles did you face in setting up a system such as this? The main difficulty was, as I said before, was not so much in setting up the bones of the system, very simple technology and web-based database system. It was mainly getting the hospitals to fill things in regularly. I do remember very clearly we would have a look to start with, and there were about 30%, and then we gradually got to 40%, and then we sort of reached a tipping point where everybody realised that everybody else was inputting the data, so they got excited by it. So I think individual hospital level ICU director is where the money is. Nadim's asked, do private GPs submit data to the national data and compile reports collectively? I mean, there are data sets that are collected through general practice. The major data set, the name escapes me, but there's a general practice influenza data set that takes a range of information, and has done for a number of years, about burden of influenza, and that was converted to COVID-19. That's just a snapshot of selected GPs, but they are private. They are their own. They own their own businesses, and they contribute data to the national data set. The other thing, of course, is the private hospitals themselves, and yes, through this intensive care database, they do provide data to the national data set. Now, AUSMAT is in Fiji, that's true. That's called the Australian Medical Assistance Teams. And the question is, would they be able to set up a system such as this? Probably the answer is no. The AUSMAT teams, as you might be aware, are sort of intensive care emergency specialists and nurses. It's true that this was driven by intensive care specialists, but Doctors Pilcher and McClure, who really led this, are very, very interested in data sets and setting up technology and so on and so forth. So you really need, I think if it was to be done in Fiji, that would need to be a request through Department of Foreign Affairs and Trade, through to the Department of Health. So this is an interesting question. Will we need to change ICU management plans as the vaccination rates increase? I wonder if that's related to individual management plans or the whole of hospital load sharing plans that I described. So I might take both sides of that question. I mean, I think at an individual level, it probably won't. Vaccination is not going to change the treatment. So I suspect the question probably meant how do we change our load sharing or our demand management systems. I mean, it's still going to be, as we've seen with exit waves in Israel, as we've seen with exit waves in the UK and potential third waves in India, regardless of your vaccination, you're still going to have a population of 10%, 20%, maybe even 30% of unvaccinated individuals. Now, that's still going to be potentially a very high burden, particularly if we get a tough influenza season. And we suspect that if we let COVID-19 continue to spread in our community without restrictions at the moment, that we would have a significant problem with intensive care admissions, given our total vaccination rates sit at about 15, that's 15% of our eligible population have had 2 doses. So I think the answer to that question is no. I don't think that the way we're managing the ICU burden is going to change. How can lay people get information on ICU admissions other than through the media? Not terribly easy. I think in the Australian context, the New South Wales government and the federal government will publish things on their website about intensive care admissions. I think that whether India has something similar nationally, but the Australian Federal Department of Health will publish in retrospect on a monthly basis the number of people with who have been in intensive care. We'll just go to the next 2 more questions, and then we might wrap up. Has Australia concentrated on making extra cryogenic tank to transport oxygen and made oxygen plants for supplying oxygen if we got a COVID tsunami? No, as far as I'm aware. Well, I can't accurately say no because I was part of the consideration of that, but I'm not sure where it went to. So there may have been consideration of excess oxygen requirements, but I'm not sure where it's up to. And the final question, any suggestions for biotech and pharma where they could effectively partner in providing support at such times? I would say my experience as the Deputy Chief Medical Officer, we had so many people from biotech firms, and whether they were startups or established, people from small pharma, big pharma, everybody was very, obviously some people were seeking contracts with government, but by and large, people were very generous with their support. So I think that the way forward, now that we've got effective vaccines, is going to be what are the next generation treatments, because between proning and dexamethasone, we probably know that those two interventions themselves give you the most relative benefit, and everything else like remdesivir or tocilizumab or really any of the other purported treatments to reduce viral load or reduce inflammation probably have very minor incremental effects when compared to proning someone and giving them early dexamethasone. So I think that's where the role for biotech and pharma is. The fight against COVID is long away from being won, and we're going to need more effective actual treatments for critically unwell people going forward. And I think, well, I've got one last question, which I'll answer there, which is, what do we see as the way out of the pandemic? Are there going to be differences between the paths used by Australia and India? Ultimately, I think the answer to that is no. I mean, it's clearly different at the moment because we're still in a situation with about 150 cases a day in Sydney that we can use restrictions to flatten the epidemic curve and remove community transmission from essentially from the community and go back to a COVID zero state, which is obviously very fortunate. But I think in time that's an impractical sort of solution. So both nations are going to be dealing with a situation where we need to maintain high vaccination rates, maintain our health system functioning for non-COVID pathologies, with COVID sort of running through our community as an endemic disease. So that's sort of where I see the future. So Dipti, I might stop there because that was great. There were 22 questions. Lovely to be able to answer them, hopefully to the best of my ability, and give people an insight into how we've done things in the ICU world.
Thank you, Nick. That was just a phenomenal. It was great to have the audience participation, and thank you for answering all the questions so candidly and honestly. And just a reminder to everyone that this webinar series is held as part of the ANU COVID-19 Peer Support Program. We've got the website for the program there. If you are a medical officer or a medical health professional and would like to either volunteer for the program or seek support, you can do that through the website or through the WhatsApp number that's listed there. So thank you very much.